Thank you very much for the invitation. Thank you very much for attending. So yes, my role today will be to introduce the topic, how can we overcome the challenges related to biomarker testing across all tumors. So before we start, I think it's good to try to answer this question. What are the clinical practice gaps? So I chose to present the results from this survey that was released a couple of years ago in the US. So this is more than 500,000 patients with advanced non-small cell lung cancer. And as you can see there, almost 50% of them are lost to precision oncology because of factors associated with getting biomarker test results. So I don't have time to go through all the details, but I think keeping in mind those 4 practice gaps helps. The first one would be access to enough input material, tissue, plasma, whatever. The second would be to try to select the best testing modality. The third challenge, I think, is probably turnaround time. Sometimes we are too late to actually make an impact on the results, on the clinical results. And finally, of course, cost. So I think it's a good opportunity to try to translate these challenges into action. So I'm going to talk about what can we do about tissue, what can we do about testing, and finally, how can we improve our turnaround time. Let's start with tissue. So here I would like to comment about a couple of things. The first one is something that worries me practically every day, and is that I'm not sure we're always considering molecular testing when we are trying to diagnose and classify the tumors. And I'm saying this as a pathologist. So we need to make a very sensible use of diagnostic immunohistochemistry. I think here less is more. These are some recommendations that we issued a number of years ago around diagnostic immunohistochemistry in lung cancer, but the same holds true for other tumor types. And the whole concept is you need to do a few IHC stains to classify your tumor. But if you're not sure after a reasonable effort what's the precise diagnosis, sometimes it's better to stop and preserve the sample for molecular testing. And the second suggestion is trying to also do a better job at selecting the best available sample for molecular testing. I call this a molecular pathology code of conduct. What I'm trying to say is that I think nowadays we are kind of lucky because our patients live longer. So sometimes we have options, we have choices. Well, the initial biopsy, then many times we have a corneal biopsy available, sometimes a surgical specimen. Of course, the cytology specimens that sometimes are obtained simultaneously to tissue specimens. And we should not forget about liquid biopsy, about plasma. So I think it's very, very good practice to keep in mind that we need enough quantity and quality to run all these molecular tests. And sometimes this is a very time-consuming task, and I'm not sure we're always doing a good job. Something that we are currently encouraging is to always record the tumor content per block in all of our pathology reports. So this saves a lot of time, and we believe that is a good way of making sure that our patients have the best available options. So this is what I wanted to share with you around the opportunities for improvement with the input material, mainly tissue. Then, if we move on to testing, I'm confused, I have to admit. There are so many technologies, so many different assays, but I think it's best to focus on the results, not specifically on the methods, and just try to understand the advantages and disadvantages of the different methods. So this is a table that depicts the methods that we're currently using to detect mutations, for example. And on the columns, you can see many of the parameters that we have to consider when we are choosing, when we are interpreting, when we are reporting molecular results. The first one would be analytical sensitivity, which is the classical limit of detection. The second one would be diagnostic sensitivity, which is the width or the breadth of the assay. And of course, there are methods that are very precise because you can know the specific variant that your patient has, whereas sometimes you only know if the mutation is present or not. The amount of input material also varies tremendously, can be very high for some methods and very low for others. And the same happens with turnaround time. Now we have ultra-fast NGS options. Of course, real-time PCR is a very fast assay, but on the other hand, some very large panels require a couple of weeks, 3 weeks, and we need to be aware of these different characteristics when we look at the different analytical options. So the last beta that I wanted to share with you in the assay part of the presentation is how important it is to integrate tissue and plasma results. We can do a plasma first approach or a tissue first approach, but whatever we do, we need to make sure that all the information is integrated and we're making sense of it. I don't like this competition between tissue and plasma. I think it's best if we try to align the results from both methods. And finally, how can we improve turnaround time? The obvious answer is trying to organize very lean workflows. As you can see there, a straight line going from point A to point B. But I have to admit that in the lab, many times, some of the workflows look like a tangled line. So it's best to try to remove as many things as possible and come up with very lean workflows. And something that also helps is if you manage to organize as many layers of communication as possible. Good teams are noisy. And something that works for us is this intra-laboratory molecular tumor board. So this is something that we implemented more than a decade ago when we started signing out NGS reports. And it's a formal meeting where molecular biologists, technicians, pathologists are invited. And we try to integrate all the information from a given patient before we sign out the NGS reports. So we think that this is a good way to releasing more sensitive information, and also it saves time when you discuss molecular results with your clinical colleagues. And this is my final slide. I'm really convinced that we need a more comprehensive perspective of cancer biomarker testing. This is an example of a lung cancer patient journey from a biomarker perspective, but it can be easily adapted to other tumor types as well. As you can see there are many challenges along the way, but there are also opportunities for improvement. And if I have to choose one single word to summarize the talk, it would be communication. I think we need to establish as much communication as possible. I'm very fond of standardized reporting. So the use of checklists helps a lot in this setting. And with this, I will thank you for your attention.
That was a very beautiful overview on the practical aspects of biomarker testing in a variety of cancers. I mean, lung cancer being a prime example. And of course, today we'll also be talking, aside from lung cancer, also prostate cancer. I think we have some time for some quick questions for Fernando before we also actually have a panel discussion later on. And I believe actually in the chat, there are one or two questions already. And maybe I'll just ask these questions, and they're actually quite related. And I think one of the questions really has to do with, Fernando, you've mentioned, I think, both liquid-based NGS as well as tissue-based. The question really is, which method is used commonly presently? And from your point of view, is there a best method? And how would you choose when you might want to use which one?
Okay, so yeah, I mean, that's a very good question, but also I think it's a very difficult question. I try not to think of methods as the best or the worst, but I think it's good to make sure that we understand the advantages and disadvantages. That's why I emphasized sensitivity, also width and input material and turnaround time. So I think one probably quick summary would be, if you're using NGS, I think there are two options: amplicon-based and hybrid capture. Hybrid capture needs more input material, and it might take longer versus amplicon-based NGS, which could be an ultra-fast option. But again, sometimes these methods are costly, or maybe they're not available in your hospital or region. So maybe real-time PCR is another good opportunity in the space, with also the use of smaller panels and a limited testing approach. But again, I think you need to consider several parameters before you choose your method.
Okay, thank you. Maybe just one more quick question, since we have a little time. This is quite an interesting question about the use of AI or artificial intelligence. Probably something to be left for the panel discussion, but maybe a quick way first. Is it prime time right now for AI and its sort of association with biomarker testing? Is that what's happening now, or somewhere in the future?
Absolutely. In fact, if I can go back to my last slide, if you can see there, like right at the beginning, it says collaboration with AI. So we are currently using AI algorithms to score PD-L1, and it's a good complementary tool. We have a pathologist in the loop, because some of these algorithms, I would say most of them are not perfect, but they are very fast, and sometimes they are more sensitive. And we're also using them to try to incorporate the infiltrating tumor lymphocytes information, because it's very difficult to score lymphocytes just by eyeballing. And finally, I think also for the proliferative index, I think that they are super helpful in some tumor types. So yes, I think AI algorithms are a new addition to a molecular tumor board. So I think they could be, even considered, as someone said, a new member of the molecular tumor board.
That's great. I think this is probably a good time for us to move on, and then we could save any of the other questions in the panel discussion later.
So now it is my pleasure to introduce Professor Herbert Loong from the Chinese University of Hong Kong, who is going to specifically give us an overview of the challenge that we have around biomarker testing in patients with lung cancer. So welcome, Herbert, the floor is all yours.
Good morning, good afternoon, good evening, wherever you are. I'm Herbert Loong from the Chinese University of Hong Kong, and it's a pleasure to join this webinar together with Fernando as well as Alicia. And as Fernando has mentioned, I'm tasked to talk about the role of biomarker testing in lung cancer. And I think to begin with, just to impress upon you, certainly, I think lung cancer is now a group of diseases instead of just one common disease. And certainly this is a pie chart that you may have already seen in various publications previously, highlighting the different molecular alterations that's present in the non-small cell lung cancer space. And what you can see are actually two circles. The outer circle actually is for the Asian population, whereas the inner circle is really for the Western population. And certainly just to impress upon you that in actual fact, the distribution of the various molecular alterations in lung cancer are different in different epidemiologies as well. Now, going back, and certainly when I was a resident, and also at the time when I first became a fellow, non-small cell lung cancer was really considered as just one disease. You would recall the seminal paper that was published by Professor Joan Schiller and colleagues in 2002 in the New England Journal of Medicine, which actually looked at the treatment of platinum-based doublet chemotherapy, be it paclitaxel or gemcitabine, in combination of either cisplatin or carboplatin in the first-line setting of non-small cell lung cancer. What you can see is that, number one, it really was considered one disease, given the fact that regardless of whichever treatment regimen you would use, in actual fact, the survival as well as time to progression was very similar. More importantly, in actual fact, these are treatment-naive patients, whereby at that time, the median overall survival of the best treatment option available was only 7 to 8 months from diagnosis. The median time to progression was only 3.5 months. Now, of course, if we fast forward now to this decade, in 2020 and certainly beyond, what we do recognize is the fact that, in actual fact, the survival of patients, based on the fact that we now have existing molecular profile of the patients and matched molecular targeted therapy, the survival is significantly longer. The example here on the left bottom survival curve, of course, is from the FLORA trial, which is first-line osimertinib in patients of EGFR mutations, where the overall survival was documented at 38.6 months. And certainly even in the ALK space, with the use of crizotinib, which is a first-generation ALK inhibitor, one that is not very good compared with what we have now. In actual fact, the median overall survival is close to about 60 months, so significantly much more than what was published in 2020. And I think the overall improvement is not only in what you see, such as EGFR and ALK, but there are certainly now, with the discovery of the various molecular alterations, we now have targeted therapies to address more than 50% of our non-small cell lung cancer patients. Not to belabor on the actual treatment options, and certainly there's a large variety of them, but I think more this slide is to impress upon you the fact that there are a variety of treatment options available, even in each of the particular molecular alterations. And more importantly, there are already existing second-line options, and there are options which are specifically targeting the resistant mutations which are generated from the exposure to, say, first-line treatment. And at the end of the day, when we think about how we can actually improve our patients' treatment outcomes and what is actually considered best practice, there are all these parameters which we really need to try to improve upon to give our patients the best outcome. I think to begin with, there's no doubt that we need to have accurate and precise pathological diagnosis. And certainly Fernando has gone through some of this point already during his presentation. And what we do know is that molecular testing is now the standard of care for patients, at least in non-small cell lung cancer. There's also, of course, a need for timely initiation of effective treatment, and the operative word here is effective treatment. And certainly there are increasing varieties of treatment, lines of treatments which are deemed efficacious, as shown in the previous slide. Lastly, of course, with all these treatments available, we need to make sure that we have good access to effective therapies. And accessibility also has to be balanced with the increasing cost of healthcare, as well as the associated disparities in the various communities. So I think to begin with, I just want to highlight some of the challenges specifically in non-small cell lung cancer. And of course, what we really need to do is identify the right patients to be treated with the right drugs. And in the notion of biomarker testing, certainly next generation sequencing is something that has been rolled out in non-small cell lung cancer. And whilst we know that the technology is beneficial to our patients, and Fernando has already gone through how that is important, at the end of the day, I've also highlighted the fact that we need to make sure that we have an equitable way of doing this testing. And one of the important aspects of making sure that this is efficient and effective are cost effectiveness analyses. Now, this is actually a very interesting project that was performed by Dr. Nathan Pinnell and colleagues in the United States, which was published in JCO Precision Oncology in 2019, looking at the cost effectiveness of doing upfront NGS testing as opposed to the other testing strategies, including, say, sequential testing, exclusionary testing, or the use of a hotspot panel. So essentially, this is a model looking at, say, either patients are tested with NGS upfront, or they may be tested in a sequence of single gene tests. At that time, in 2019, the only FDA-approved treatments includes EGFR, ALK, ROS1, and BRAF. And if those were negative, then consider an NGS. Another approach may be to do an exclusionary test, where in actual fact, the largest population are actually KRAS mutations. Now, again, at that time in 2019, KRAS mutations were not actionable, and the presence of a KRAS mutation is typically mutually exclusive from other actionable drivers. So therefore, if you test a KRAS first, which could be done in a relatively simple PCR test, and if that was positive, then you could actually stop the testing strategy and maybe be able to save some money. Lastly, you may consider doing a hotspot panel. Now, overall, with these models, what they have determined is that based on the United States healthcare system, in both public or sort of Medicare insured patients, as well as commercially insured patients, upfront NGS testing was able to be associated with cost saving, as well as a shorter time in terms of generation of results for both the Medicare as well as commercial payers. Now, that is the situation in the United States. In the Western population, but as mentioned previously, we know that the molecular epidemiology of actionable mutations in non-small cell lung cancer are different in different localities, and certainly in East Asia, where I'm from, we know that our predominant population is EGFR as opposed to KRAS, and EGFR is an actionable mutation. So therefore, if we use the same strategies that Dr. Pinnell and colleagues have considered, but actually use an exclusionary approach where we do an EGFR test first for our patients, and in the patients who are, say, positive, we may consider no longer needing to do further testing, we may be able to find an even more cost-saving method of testing strategies. And that is exactly what we did, and this is one of the projects that I headed based in Hong Kong, looking at the testing strategies for non-small cell lung cancer in the upfront setting in East Asia. And essentially, we used the same model that Dr. Pinnell and colleagues used, but we inputted our local molecular epidemiological data, as well as our costing data, and going through the different strategies again, whether or not patients should consider doing upfront NGS, or the consideration of, say, an exclusionary test or a sequential test. And what we found, in actual fact, is if you look at these different parameters, including, say, the cost of the entire cost to the, say, healthcare system for testing patients, the time to appropriate therapy, the number of actionable alterations identified or the non-actionable alterations identified, different testing strategies do have different pros and cons. So certainly, if everybody that you see with non-small cell lung cancer is given an NGS test, it would be the most costly for the government. But if we actually do an exclusionary test where all the patients do a simple PCR test first in their samples, and again, if EGFR being positive, then they could stop testing, and only those which are negative then go on to, say, an NGS, that was actually the most cost saving in terms of the approaches. Now, what we've also found, which was actually a bit surprising, is because we have such a large EGFR population in our population, doing an exclusionary test and be able to come back with a turnaround of within a week with an EGFR positive test, and then therefore be able to start the patient's treatment early, the time to appropriate therapy for the average patient was actually faster in the exclusionary test as opposed to NGS, and of course, doing a sequential test would take the longest. There's no doubt that if you use an NGS test, you'll have 100% of the patients being able to have their actionable alterations identified, but certainly an exclusionary test also gives you about 90%. And in situations where there are non-actionable alterations which need to be identified, for example, in clinical trial settings, of course, the different techniques do have different pros and cons. So overall, what we have established is the fact that the outcome is influenced by the high prevalence of EGFR mutations in the East Asian population in non-small cell lung cancer. And this can actually be readily detected in single gene tests. What we do know is that exclusionary testing does not capture all the possible genomic alterations, and the more non-actionable genomic alterations become actionable, and as well as the fact that NGS testing is becoming cheaper. Upfront NGS may potentially be a cost-saving option in East Asia as well. Now, just maybe a short break from all the very heavy information, I've decided to also bring forward a case for discussion, which would be able to also segue into the next part of my talk. And this is one of the patients that we treated about 3-4 years ago, which is a relatively elderly patient with a long list of medical history, who actually had a stage 1A moderately differentiated adenocarcinoma of lung, and that was in August 2020. At that time, he was able to go ahead with surgery with a right VATS with upper lobe and middle lobe wedge resection, and subsequently the sample was sent for EGFR testing with a single analyte test with PCR and confirmed to have exon 19 deletion. Given the fact that this was an early stage disease, as well as the fact that this is a relatively elderly gentleman, the plan was for close observation and not to start any adjuvant treatment. And close observation was deemed with serial imaging as well as monitoring of the CEA. And in actual fact, about a couple of months after the initial surgery, the surveillance CT scan started to notice some non-specific ground glass opacification in the right upper lobe of the lung. And subsequently, about half a year later, the serial monitoring of CEA also showed an elevation to 24.8. So this was the PET-CT that was performed in March 2021. As you can see here, there's evidence of local tumor recurrence in association with some hypermetabolic soft tissue at the lateral inferior aspect of the right upper lobe, as demonstrated in the PET-CT, and this is suspicious of malignancy. There's also some irregular hypermetabolic nodular thickening along the right fissure, as well as the right pleura, suspicious of tumor deposits. So unfortunately, this patient has disease recurrence. Now, at that time, the patient was started on osimertinib first line, but he was deemed to be refractory to treatment and developed worsening symptoms even with osimertinib. And then a couple of months later, developed hemoptysis, and a reassessment PET-CT actually showed further evidence of disease progression. A bronchoscopy was done at that time, mainly because of the fact that he was coming in with hemoptysis, as well as evidence of some obstructive pneumonia. And it was shown that there was blood over the whole right lung-dependent area of the right lower lobe, with some fresh blood in the RB3 and RB4, and required some local adrenaline instillation to stop the bleeding, and a subsequent biopsy was taken. So here we are at the polling question. Given the fact that we've taken the biopsy, the question is, with this situation now, what is the biomarker test that you might want to consider for this particular patient? A, would we consider repeating the EGFR test based on the bronchoscopy specimen to see whether or not EGFR is still present or absent? 2 is maybe perform a PD-L1 test on the bronchoscopy specimen. 3, C is to perform a tissue-based NGS test. D is to perform a liquid-based NGS, a liquid biopsy. Or E, there's really no need for biomarker testing. Let's just go ahead with chemo IO, such as the Keynote 189 regimen for this particular patient. Okay, so I think a lot of the results are coming in as we speak, but it does seem as though predominantly most of our attendees think that C, to perform a tissue-based NGS testing on the bronchoscopy specimen, is the right thing to do. And certainly that's our view as well, given the fact that we already have a tissue specimen available. And that is exactly what we did. We did option C, and we did perform an NGS on that bronchoscopy specimen, which showed the presence of the EGFR exon 19 deletion, as well as the presence of MET amplification with a 3+. So in actual fact, given the fact that there was MET amplification, it allowed us the concurrent use of osimertinib and tepotinib as per the INSIGHT 2 trial. And in actual fact, after the starting of tepotinib, which is a potent MET inhibitor, there was a decrease in the CEA during the serial monitoring. And in actual fact, a PET-CT subsequently done shows the evidence of metabolic quiescence. And based on the radiological findings, there was significant improvement. And clinically, there was also improvement with resolution of the hemoptysis-like symptoms. So, I mean, I think I've shown some of the advantages and some of the champions of biomarker testing. And certainly in that case, with biomarker testing, we're able to change our treatment strategy and create a great outcome. But at the same time, the question is, what are some of the remaining challenges that we have? And I think it's worthwhile also highlighting these issues as well. And in actual fact, Fernando has also shown you the information from this particular slide in his presentation, but this is just presented in a slightly different way, really looking at the different challenges that our patients actually face when it comes to like molecular testing, going through the different hoops and hurdles of getting the specimen and then getting the test done, and then subsequently having that result being read out to the patient, and then therefore also at the end of the day influencing treatment. And I think a lot of times what happens is patients actually don't really realize the difficulties or the challenges or the different hoops and hurdles that we have to go through, or the specimen actually has to go through, before we can actually reach a point where we can make a treatment decision based on the initial biopsy. And for example, in situations such as this, there can be issues in terms of, say, the specimen collection. Maybe the initial biopsy had insufficient tissue. Maybe the biomarker testing was not ordered appropriately. Maybe there was a delay in the release of the biomarker testing results, or targeted treatment was not done despite positive biomarker test results. So all these are challenges that we really need to try to improve upon. And when we think about the challenges, it's not only the analytical or the preclinical testing that's a challenge. The other challenge, of course, is the timeline that affects our patients. And certainly this is just a cartoon showing you that in actual fact, when the patient sees you as the oncologist, they were probably already initially seen by their primary health provider, maybe more than a month ago, and at that time already seen a surgeon or an interventional radiologist or a pulmonologist to do a biopsy, and then they come to you. So the diagnosis was probably already made 4 or 5 weeks in advance. And by the time when they see you, then you consider orders, say biomarker tests. That takes another 2 or 3 weeks. Certainly PCR tests may be a bit quicker, but NGS tests may take about 3 to 4 weeks. And then the worrisome thing is that if there's not enough specimens, or if the specimen is of poor quality, there may be further delays requiring the need for rebiopsies, etc. And I think it is important for us to consider whether or not we can move the process of biomarker testing earlier. For example, if we can actually get that already done as a reflex test prior to the patients being seen by the oncologist, and certainly even the consideration of using liquid biopsies, which actually has a faster turnaround time. And this is mission critical for us. Now, if we're able to address some of these challenges by moving this time up front, for example, if we can consider biomarker testing at the time of, say, clinical suspicion, or if the pathologists have already got a approach of reflex testing immediately after the histological diagnosis, or the consideration of using liquid biopsies to detect circulating DNA, after the pathological confirmation of non-small cell lung cancer, we are hopefully able to advance this and also shorten the timeline, and then therefore be able to start effective treatment at an earlier time point. And just a quick segue about liquid biopsies. Again, Fernando has talked to you a bit about this already, but certainly when we talk about liquid biopsy, typically we're talking about the analysis of cell-free DNA or tumor DNA that is actually in the blood circulating. And certainly when will we consider using it? We'll consider using it when we say do not have adequate tissue available, or if biopsy is not possible. Or the other possibility is when we're actually looking at treatment resistance, especially to tyrosine kinase inhibitors. The advantage, of course, is the fact that it is minimally invasive and may overcome tumor heterogeneity, given the fact that you are getting a collection of cells from all the different tumors within the body. At the same time, though, there are limitations. The sensitivity has been quoted about 70 to 80%. However, the specificity is near 100%. And I think what's important is if you have a positive result, it means that the mutation is actually there. But if you have a negative result, it may not necessarily be informative, and therefore you may need to consider doing a tissue biopsy in that situation. And based on the ESMO guidelines for liquid biopsies, liquid biopsy assays are actually very highly analytical and clinical specific. There are these limitations, as I've talked about earlier. A liquid first strategy is recommended as an alternative option to tissue genotyping when time to result is important, or tissue biopsy is unavailable and appropriate. And also, blood samples should be collected when cancer is progressing, either at treatment naive or after prior lines of therapy. And again, Fernando has also shown you this diagram, but just to highlight the fact that now the incorporation of, say, liquid and tissue really should not be a fight between the two, whereby in actual fact, what we are considering is the fact that each of them have their distinct advantages. And one additional approach is, instead of considering liquid or tissue, is of course to do a complementary approach where both is actually done. And in actual fact, the information may complement each other, and therefore be able to give you a more comprehensive view of the molecular genotype of the patient's tumors. So at the end of the day, what we need is good quality biopsy specimens to be taken at the first attempt. So our pathologists, such as Fernando and colleagues, would be able to give us the answers. We need to make sure that we incorporate molecular testing as a reflex test in the pathology department. As the cost of NGS is actually coming down, NGS reflex workflow to incorporate RNA-based testing in either concurrently with DNA or in the event of DNA being non-conclusive. And of course, establishing the role of liquid biopsies as a complementary testing method is something that's important as well. And with all this in place, NGS becomes cost-effective. So with this, I'd like to end, and I'll be happy to answer any questions that you might have.
Well, thank you very much. So that was a great presentation. So let's start by something that also intrigues me, and I think is probably a question that we all have asked ourselves or colleagues at some given time, and is, can we recommend chemotherapy or start chemotherapy while waiting for the NGS results? Because as you know, sometimes they take too long. I have to say, as a pathologist, that is a difficult conversation sometimes in clinical tumor boards, molecular tumor boards, when you as clinicians have a patient that cannot wait even a week or 10 days or 2 weeks for an NGS results to be ready. So your thoughts around this, Herbert?
Yeah, I mean, I think that's a very valid question and something that we face all the time in clinical practice. I think the bottom line is, if there is a clinical emergency where there's a need to start treatment early before your NGS test comes back, and even if you're already using liquid, you're already increasing the sort of shortening the time, I would think it does make sense to start off with some treatment. And certainly I think using chemotherapy, if say it's an adenocarcinoma, then pemetrexed plus a platinum-based doublet would be the choice. And I don't think it would be wrong. I think that would be the right thing to do. I think my only question and my only caution would be, given the fact that there is potentially a chance you may be using a TKI later, or you may change the treatment if you come back with an actionable mutation, I would hold off on using the immunotherapy or the checkpoint inhibitors until you get the NGS results, even if, say, the PD-L1 is more than 50%. I think the issue is, if it comes back to be an actionable mutation, you have a TKI that you have that's available, but if the patient has already been exposed to immunotherapy, in general, there are increasing risks of pneumonitis as well as other overlapping toxicities. So that might be something you might want to avoid, and only then consider using the addition of immunotherapy after you have the NGS or the biomarker testing results and you're planning to continue with a chemotherapy-based treatment.
Okay, thank you. Yeah, I think that's a very, pragmatic recommendation. So thank you, because we had a couple of attendees that were asking the same question. So another one that I think is also interesting is, when do we assess for effectiveness of treatment? Because we've all heard that targeted therapies are usually very, very effective. So, but unclear, it's a matter of weeks, months. How do you assess response? And also, I think if you can give us a very down-to-earth path, it will help, I think, everyone in the symposium.
Yeah, I think, we try to make sure, I think to begin with, for any treatment that we give, we need to make sure that we have a way of assessing response. Any treatment is toxic, regardless of how little side effects that some of these new drugs have. So we need to make sure that we have equipoise to know that we are giving, a potentially promising treatment to the patient. Now, for us, we typically monitor patients with imaging. Of course, in clinical trials, typically it's every 2 months. I could tell you that practically speaking, it's quite difficult to get scans every 2 months for our routine patients here in Hong Kong. We try to get it at least in the first 3 months or so to get a set of scans. We actually rely quite heavily on CEA in some of our patients, if that was actually high to begin with. And of course, symptomatic improvement is something that we look into as well. You'll be surprised by the number of chest X-rays that we still take. You can see in the case discussion, I actually showed a patient with chest X-rays. And I think, practically speaking, unless you have very good access to a lot of the different modalities, I think it's a combination of all these assessment tools to really give you the impression as to whether or not the treatment is working. I think one very important aspect, which I did not mention, is I think we're finding it more and more important that we also make sure that we image the brain, because that seems to be a sanctuary site for some of these actionable mutations, tumors with driver mutations. So therefore, if there's anything that, if I have very limited resources, I'll be happy to make sure that I follow the patient with CEA and a chest X-ray, but I want to save my resources for imaging the brain. So that may be something that's a bit more practical, which I think the audience may be interested to find out.
It is my pleasure to present Professor Alicia Morgans, who is a medical oncologist based in Boston at Dana-Farber Cancer Institute. And she's going to address the same topic, but this time in a different tumor type, in prostate cancer. So welcome, Alicia.
Thank you so much. And what a really exciting conversation we've had today. And I so appreciate everyone's expertise. So when we think about prostate cancer, I think similarly, we have to recognize that this is an extremely aggressive disease. And we do have an evolving and increasing number of treatments, but certainly still metastatic disease at this point in time remains an incurable disease. And this is where we're really trying to focus our understanding of biomarkers to try to improve our utilization of targeted therapies. I think we also recognize in prostate cancer, similar to lung cancer, that there are these alterations, particularly in the homologous recombination repair pathway, that are associated with the progression and development of prostate cancer. And certainly, as we see patients with BRCA2 mutations, which are the most common HRR mutations in prostate cancer, we can see here that they have an 8.6 time increased risk of developing prostate cancer by the age of 65, and an elevated risk with BRCA1 as well. And so these alterations are so important to identify for family risk considerations and screening, as well as for targeted treatments. I think we also recognize that we can have these alterations in the germline, so something that the patient has inherited from their parents, or somatic, and that both of these can be important in different ways, with germline mutations having implications both for family members as well as for treatment options, and somatic mutations, of course, having opportunities for us to target with treatments. And we have found similar effectiveness generally with mutations being targeted in both the somatic and germline setting, although certainly we don't have the family implications if we do have these acquired somatic mutations that arise only in the setting of the tumor cells themselves. I think, tumors can develop in the context of either of these situations, as we've just said, and germline mutations are coming from a parent where we can have an inherited defect copy, and then the other copy that's been maintaining the patient's genetics over the course of their lifetime can undergo a second hit. And this biallelic loss can really drive tumor progression, development, and progression. In the setting of a somatic mutation, initially patients are born with normal copies of these genes, but over time, there can be one hit that causes a monoallelic loss in BRCA, for example, and then a second environmental impact can lead to that loss of the second copy of the gene. This can lead, of course, to the development of cancer. And I think we really have to consider these mutations in the HRR pathway or the DNA repair pathway and how they can lead to these development of alterations. We can see here that when there are alterations that develop in the genes or in the DNA, these can be repaired by different pathways. And it is double-stranded breaks that are really addressed by the HRR genes that we can see listed here, including BRCA1 and BRCA2, BRCA2 being the most prevalent in our patients with prostate cancer. But we also have to think about PALB2, RAD51. And really, this is a way for the cells to repair double-stranded DNA breaks. And without them, these breaks and alterations can build up and lead to severe dysfunction in the cells. I think as we've heard today, though, genetic testing is important in multiple different types of cancers. We've heard about this specifically in lung cancer, and in prostate cancer, we can use our genetic testing to help inform our treatment decision-making and give us opportunities to use certain treatments. And understanding patients' family risk and then performing their germline and somatic testing is the way that we can inform the clinical decisions, understand implications for family, and also understand our treatment options. As I've mentioned, DNA repair defects can be common in advanced prostate cancer. If we look on the right side of this slide, this is demonstrating among patients who have germline genetic alterations with metastatic prostate cancer that BRCA2 is making up about 44% of these, so a large majority of these. And in metastatic prostate cancer, it has been suggested that 12% approximately of all patients with metastatic disease may have one of these HRR mutations. And importantly, this is actually not necessarily associated to the age of diagnosis. So you don't have to be a very young person to get diagnosed to have this risk of 12%. And it's also not directly tied to family history. So this is in an all-comers population, it's approximately 12%. And that's, I think, really important to recognize. In the somatic setting, or when we consider somatic alterations, about 23% of patients with metastatic castration-resistant disease, so more advanced disease, have these alterations in DNA repair defects. And they're certainly more common in patients with metastatic prostate cancer than they are with localized prostate cancer. And here we can see the estimated mutation rate for patients who have metastatic castration-resistant prostate cancer, BRCA2 leading the way, but notably about half of our alterations are identified in somatic testing with BRCA2 and about half with germline testing, with a combined rate here of 10 to 11% of mutations. PALB2 is actually one that seems to be also quite responsive to our targeted treatments with PARP inhibitors, and it's more commonly found in somatic settings. And we can see here MSH2 and 6, which can be associated with Lynch syndrome and may be targetable with things like pembrolizumab, more common also in the somatic setting. I think when we consider BRCA2 specifically, which again is the most common HRR mutation identified in patients with prostate cancer, we also have to recognize that this is going to confer a more aggressive phenotype and leads to a poorer prognosis in our patients with prostate cancer. So identifying these mutations help us identify a population that is at risk, whether they have localized disease, as we can consider, or whether they have advanced disease, they have poorer outcomes to treatment. And time to progression to mCRPC is faster when patients have BRCA2 as compared to a wild type version of the gene. PARP inhibitors can be used to target these BRCA mutations, and this is because the functional copy of BRCA2 comes in to repair those double-stranded breaks, but when we use a PARP inhibitor to stop that function, those breaks build up and lead to cell death because they're really unable to complete their function. And there have been multiple studies that have investigated PARP inhibitors in prostate cancer. These have led to multiple approvals and indications, and we'll get to that in the second part of my conversation. But you can see here that the drugs that have been assessed include olaparib, talazoparib, and niraparib, and they're really being tested in mCRPC, metastatic castration-resistant disease, and moving into tests looking in the hormone-sensitive setting as well. So let's talk through a patient case. Mr. GC is 68. He has a history that's pretty unexciting with just hyperlipidemia, but a family history of a grandmother with breast cancer. He has a PSA that was elevated at 12.6 and imaging that demonstrates that he has a concerning lesion in the prostate. He underwent biopsy, and this demonstrated a high-grade, grade group 5 prostate cancer in 5 of 12 pores. But he underwent bone scan and other imaging that showed that he does seem to have localized disease. Should he undergo genetic testing for this high-risk prostate cancer? Let's take a moment and answer now. Either no, because of no family history, no, because he doesn't have he only has one first-degree relative, or yes, because he has high-risk prostate cancer, or yes, because all patients should get germline testing when they have prostate cancer. Okay, so it looks like half of people said yes because he has high-risk localized prostate cancer, and that's absolutely right. That's regardless of family history. And here we go. We can see the hereditary guidelines here suggesting that for all patients who have high-risk prostate cancer, sort of middle down the slide, these patients are recommended to get germline testing. And this includes considerations for pre-test counseling, telling patients about the risk of potentially needing cascade testing for family members if they're positive. And we also have to think about providing post-test counseling for patients who have these mutations so we can help test family members. So he does undergo this testing. And we can see here there are multiple ways that we can test. Germline testing is typically done through a blood test or buccal swab testing. And you can also use things like blood-based analyses, but somatic testing is really done through tissue testing, circulating tumor DNA, and there was in the past a focus on CTC testing, though that's not used in clinical practice at this time. So he discussed the high-risk disease at length and underwent a prostatectomy, did well post-op, but did have a recurrence. This showed that he had a sternal lesion, and that was consistent with metastatic disease. So should he undergo additional genetic testing at this time? Please take a moment and answer now. Thank you. So yes, he should undergo somatic testing. Now he has metastatic disease, and this is actually metastatic castration-resistant disease because he was on ADT. And how should he undergo this testing? Please take a moment and answer now. Okay, so buccal swab is not suitable, and that's correct because this is for germline testing only and is not going to tell us about somatic testing. And apologies, I sort of missaid that question when we first got it. So I think I confused everyone. You can use options B, C, and D for somatic testing, but not option A. We can't use buccal swab testing. Tumor testing has to be done or can be done as an option for somatic or germline mutations, circulating tumor DNA also. But germline testing is the only one that really can be done with a buccal swab. So that's important to remember. And we have to think when we do circulating tumor DNA testing that this is going to be most effective in a setting for high PSA and with high volume prostate cancer, as well as metastatic CRPC. And when we think about circulating tumor DNA, recognize that ATM mutations have a high risk of false positive because of the interference of CHIP with the assay. And so the guidelines do recommend for metastatic disease that we do somatic testing, particularly when it gets to be mCRPC. And we really need to do a multi-gene panel to look for all the options for treatment. Moving on to think about our options for treatment, as I said before, multiple PARP inhibitors have been assessed as single agents or in combination. This has led to approvals. The first study was really done as a single agent with olaparib here. We can see in a selected population with HRR mutations that treatment with olaparib improved progression-free survival on the left and overall survival on the right. Rucaparib has also been assessed in this setting in selected populations. This was with BRCA1 or BRCA2, and we can see that they had a decrease in measurable disease on the left and a decrease in PSA on the right. And Triton-3 was a first-line metastatic CRPC setting, also testing rucaparib, which showed in the upper left that when compared to treatment with docetaxel, rucaparib actually beat docetaxel in an HRR-selected patient population. It also beat AR pathway inhibitors in this setting, but only really in that BRCA subgroup. On the right-hand side, you can see that ATM subgroup does not seem to respond to chemotherapy or ARPIs specifically. ATM is a little bit confusing. We also have options to treat patients with pembrolizumab when they have high MSI high or high tumor mutational burden or have those Lynch syndrome, mismatch repair deficiency syndromes. And we can see that this occurs in approximately 2 to 3% of patients who have metastatic CRPC, and we can see radiographic responses, as we see on the right-hand side of this slide, with treatment with pembrolizumab. Combinations are also used now in first-line mCRPC. These were tested because there appears to be a synergistic relationship between inhibiting PARP and inhibiting AR signaling in this setting. And there were multiple studies looking at this, including TALAPRO-2, PROPEL, and MAGNITUDE, looking at olaparib and abiraterone, niraparib and abiraterone, and talzoparib and enzalutamide. And in all of these settings for BRCA-mutated patients, we can see that there's an improvement here in radiographic progression-free survival, although this was not necessarily consistent when we look at patients who have non-deficient HRR. And we can look at overall survival. Also, it appears to be a trend towards improvement with the treatment with the combination of an AR signaling inhibitor plus a PARP inhibitor in these settings when patients have BRCA mutations. And this has led to sort of different approvals in the EAU versus the United States, but in general, single agent olaparib has been approved for treatment, as well as single agent rucaparib in the United States, though this is not really available at this time. And there's an approval for olaparib abiraterone in both the US and in Europe. It's only approved for patients who have BRCA1 and BRCA2 mutations in the United States. In Europe, it's a broader HRR, all-comers label. Niraparib and abiraterone approved in both settings for patients with BRCA1 and BRCA2 and mCRPC, and talazoparib and enzalutamide approved for patients who have HRR mutation. And we're also looking at these in the setting of earlier phase disease and metastatic hormone-sensitive disease, as we can see here. So for this patient case, the patient underwent somatic tissue testing of the prostatectomy specimen. We can use older specimens to do this somatic testing if we have to. Patients with prostate cancer often have metastatic disease that's bone only. It can be hard to get a sample and then do the testing. So prostatectomy is an option here if you can't do circulating tumor DNA. And we do prefer tissue with prostatectomy over circulating tumor DNA because of the interference with CHIP. This patient had a BRCA2 mutation. He meets criteria for treatment of his mCRPC with either abiraterone, enzalutamide, docetaxel, or a combination. And what we can see here is that he had a shared decision around the different factors associated with each of these treatments. He wanted an oral treatment. He wanted a targeted treatment. He didn't want to lose his hair. And so he moved forward with the combination of abiraterone and olaparib. And this was thought to really give him what he was looking for. So his PSA did seem to respond from 4.3 down to 1.67. So in conclusion, germline testing was used here and can be used in advanced prostate cancer to identify patients whose families need cascade testing. Multiple options for testing are available. That can be somatic, using prostatectomy tissue, as I mentioned, a new biopsy, a new prostate biopsy, a metastatic biopsy, or circulating tumor DNA. Germline testing with a buccal swab or plasma testing can be done. And genetic testing in patients with advanced prostate cancer can really identify patients who can get these targeted treatments. And it's also important to be done for their family members as well. And in prostate, we use both somatic and germline testing. Thank you.
Well, thank you very much, Alicia. That was very comprehensive. I particularly enjoyed your slide where you compare germline and somatic testing, and also the whole concept of biomarker testing in prostate beyond BRCA, because I have to admit that sometimes the field can be a bit confusing. I think there are a few questions in the chat that are addressed specifically to you. So first one, and I think it's also a matter of controversy in other tumor types as well, is how germline and somatic mutations differ clinically. Your thoughts around this, because and also I would maybe add, and that's my own curiosity, how do you organize in your clinic germline and somatic testing? Because I know in some places they prefer to go first for the somatic and then germline. Other places say, oh no, my germline strategy is faster. How do you do it in real life? And if are there any differences in the outcome or the follow-up of these patients?
So I think in my clinic, I often get germline testing first because I'm seeing many metastatic patients. And so I'm trying to understand potential targets, not necessarily when they have new metastatic disease, because I can't use the treatments then, but I can use them when they progress and I can inform their family members. I think that there are other groups who prefer to do a somatic testing first and then reflex to germline if they find an alteration like a BRCA2 that may have implications for family. But I would say that there have been multiple presentations that have really demonstrated that we're missing a fair number of germline mutations if we take that approach. And I think the implications for family are so concerning that I always try to do both, and I do start with germline. But where resources are limited, we always have to make these decisions, and so it can be what is available. If all that is available is somatic, then that is a reasonable place to start.
So we also have, I think, a question that is kind of related to this one. And the first part of the question is something like this: should every prostate cancer patient undergo sequencing, or are there any specific indications for the same? So I would like to rephrase the question. I mean, are we ready to accept upfront NGS testing in all of our patients with advanced prostate cancer, as we are starting now to accept in other tumor types? Although I have to say it's been a painful journey. How are we as providers, as patients, scientific community ready for this change of paradigm, or how do you envision this trend?
I think that at this point in time for prostate cancer, from a resource utilization perspective, that can be really challenging. And in areas where resources are everywhere, we are using NGS for all of our metastatic patients, or at least all of our metastatic castration-resistant patients. That's where the treatment options really begin. But in places where we don't have the resources, there are multiple other options for treatment. And so sometimes we have to prioritize getting a different treatment for a patient rather than doing NGS. But it's evolving, and more is becoming a standard of care.
Okay, so there's another related question before we move on to the general discussion. And it's, is there enough evidence to test for HRD or HRR in prostate cancer? Because only BRCA1 and BRCA2 mutations seem to benefit from PARP inhibitors. Why testing them for other aberrations? So kind of the same topic. I mean, do we need that much information if we are not going to use it? So I think also I wanted later on to involve Herbert, because I think this is probably one of the most controversial topics now in cancer biomarker testing.
I think it's a great question. There are targeted assays, and I loved Herbert's sort of, if we test this and rule this in, then we can rule everything else out. I mean, I think that's a really great strategy. We have not seen that level of certainty and that kind of an algorithm develop in prostate cancer. But again, in resource limited places, I would say if you have access to a targeted treatment rather than, NGS complete, then HRR is what you would want to start with. And then understanding if the patient, even by IHC, has a mismatch repair alteration defect, I think might also be helpful if you have access to pembrolizumab, but that's not actually a treatment option available everywhere. So for now, it is do what you can do in terms of your resources, and the HRR mutations are the ones you would want to target if you have access to those as treatment.
Not only BRCA1 and BRCA2. No, I think that's another also very important message.
Yes.
Yes. Okay, beyond. Okay, excellent. So let me see if there's some. We have a few questions around the AI use, but I think we can address them all together. Oh yeah, maybe there's this one. I think it's worth considering, because again, we have lots of questions in the chat, but we're trying to focus on the ones that are related to the topic of today's conversation, which is challenges around biomarker testing. So are there any biomarkers that indicate aggressive or indolent form of prostate cancers, and do they influence treatment decision? Yes, so kind of the same question, but what do you use in the clinic? Also, someone else asked, how do we grade prostate cancer? Do you do something? What's the effective method in grading prostate cancer? Pathologists, maybe?
Yeah, the pathologists are great. They've been using Gleason scores, and they've converted that to Gleason grade group in the last few years. And so that's what we really use to grade our prostate cancers. That's important because the high grade prostate cancers are actually, even when they have localized disease, should undergo germline genetic testing. Beyond that, there are other biomarkers that people look at just to sort of think about more aggressive cancer types, but it's not to target treatment. These might be cribiform features or intraductal components, but these are really kind of icing on the cake when it comes to prognostication, but they're not targetable things at this point in time.
So the first thing I'd like to ask you both is, how do you prioritize which biomarkers to test in lung and prostate cancer patients in resource-limited settings. We all want, upfront NGS for all of our patients. I think in the case of prostate cancer patients, we need, I think, very large panels if we really want to do a good job at looking into HR and TMB and microsatellite instability. So, these panels are expensive and cost, and sometimes the turnaround time is really long. So try to position yourselves in a situation where you really have to, maybe organize a more cost-oriented testing workflow. So Alicia, I'd like to start with you. What would be your suggestion in prostate?
So if we really had to focus on the patients with the highest prevalence of these alterations, which is probably what we would do in prostate, because we don't have those elegant kind of approaches like Herbert's described, which is just lovely. I would say this would be a metastatic castration-resistant prostate cancer setting where we know that the prevalence of somatic and germline mutations is actually quite a bit higher. We would not be testing in localized disease. And I think that we would probably focus on either germline or somatic, but if we focused on somatic, then we could reflex to germline for those patients who have an alteration. And if we really had to conserve resources, that's how I would do it. So MCRPC somatic, and then reflex to germline only when positive or in the setting of a very, very strong family history, perhaps.
Okay, that's really helpful. So using really clinical information to make sure that you actually testing patients that are going to benefit most from the information. Okay, Herbert, your thoughts around this, because you've done a ton of work around different strategies, and you publish really I think important information that I think is helping many of us in the field of lung cancer consider how we organize upfront NGS versus sequential testing, exclusionary testing. So resource-limited setting, some thoughts around this?
I think as discussed during my presentation, I think to begin with, you really have to know the molecular epidemiology and the landscape that your center or wherever you're practicing is, because that actually has great implications on the testing strategy. So for example, as mentioned, in Asia, we have an EGFR predominance. So EGFR testing, rapid turnaround time, good specificity and sensitivity for PCR testing. I mean, it is pretty much the gold standard that NGS is comparing to, and therefore being able to test that first to have the turnaround, and then to only then consider a larger panel testing for patients who test negative. Now, I think this, of course, all hinges on the fact that there is always been a belief that actionable mutations are mutually exclusive. Having said that, I think as we are doing more and more large panel testing, we are seeing that there are situations where patients may have more than one actionable mutation being present. Generally not very common in the treatment naive setting, but I would caution doing this type of approach in patients who are actually showing resistance to targeted treatment, because we do see, off-target resistant mechanisms being other MAP kinase pathways, which can be actually potentially be missed if you don't do a larger panel test. So, for example, in EGFR, if there could be a MET amplification. We've had seen patients who say RET fusions, which subsequently have NTRK changes, or EGFR patients with RET alterations being the resistant mechanism. So I think we just have to be mindful of what the molecular epidemiology is, and ultimately at the end of the day, I think also depends on the accessibility of the various drugs that you have in your particular setting. Having said that, I would still try to find these alterations, because there's a possibility that even if you don't have the drug access, you may be able to refer to clinical trials even elsewhere out of the country. Many a times now, especially for the rarer mutations, you'll find that sponsors of clinical trials are willing to also support the travel costs of patients to treatment centers, which may be outside your country, and that may be a good option for some of your patients.
I think that it was very interesting that you brought up the issue of molecular epidemiology, because I'm really fond of this concept, and I don't think we are really using it to organize our testing strategy. So we had a couple of questions in previously in the chat. One was about the frequency of EGFR mutations in Africa. So do you have any recent information, Herbert, or still the data is still immature to make a final call?
Honestly, I don't know. I think that's definitely something worth looking into. And I think we also realize that, of course, there are genetic aspects to it, but also environmental aspects to it as well. And, I think it's not well documented in Africa. And certainly, I think, sub-Saharan Africa versus other parts of Africa may be completely different as well. So I think it's worthwhile looking at this.
Yeah, exactly. And we also had another question around the percentage of NTRK fusions in large cell neuroendocrine lung carcinomas. What are your thoughts about this?
Well, that sounds like a question for you, Fernando.
Okay. Well, I tried to get off the hook, but couldn't. Yeah, this is interesting. I wanted to send out the message that large cell neuroendocrine carcinomas, in fact, might contain NTRK fusions and RET fusions as well. And I think this has been underemphasized in the literature. So we don't really know. This is not a frequent tumor. There are no really consecutive series of patients that have been systematically studied. But I think the main message is, if you are in front of a bona fide large cell neuroendocrine carcinoma of the lung, I think it might be a good idea to make sure that you rule out an actionable fusion, preferably using an RNA-based NGS panel. I think that could be a fair statement for now. So, and regarding the concept of multidisciplinary work and how important it is to participate in clinical tumor boards and molecular tumor boards, I would like to ask you both, how do you do this in your institution? So I will start with you, Alicia. What are your thoughts? Maybe any future prospects? What do you find the most rewarding or most challenging when you attend these gatherings?
I think that the gatherings themselves are extremely rewarding because people are able to help you kind of pick apart some of these NGS testing reports, which can be really complicated at times. And at least the ones that we get, often some of them will tell you, okay, here's something that we think is pathogenic. Here's something that we are not sure is pathogenic. You can look at the frequency of the mutations in the sample that's been identified. And it's really nice to have a molecular pathologist speak through that with us as a team and say, okay, I think that this is pathogenic or pathologic as a mutation, but it's not really it's present in 0.01% of, so it's probably not the driver for the majority of these cells, or this is pathogenic and look, it's present in at least half of the cells and you really need to go after it. So this can be really rewarding. It is challenging to get everyone together at the same time. And also, we aren't all able to have a molecular pathologist within our group. So I think increasingly things like Zoom and other online platforms to allow this communication across many different centers, as an example, bring everyone together and have us all talk together, but do it on Zoom, can be really, really helpful, because I wish there were more molecular pathologists, but there just aren't enough of them in the world. And bringing them to the people and the teams that need them is really important and rewarding.
Herbert, how do you do this in your institution?
Yeah, I think, again, the rate limiting step is the presence or the number of molecular pathologists. I think it's very difficult for us to come by those individuals. So we try to have molecular tumor boards actually in combination with our regular tumor board to make sure that we allocate time to discuss the molecular cases. And I think to begin with, a lot of our patients, most of our patients get NGS now in-house, so that we're quite comfortable with. But certainly we still have a large number of patients who get NGS from a commercial panel or from an outside referral center. So just making sense of the reports, or more importantly, making sense of some of the trial or treatment recommendations. I mean, they'll always suggest something, and whether or not that's really something that you can consider using, I think that's where the tumor board comes in, and where we have a consensus and a group discussion. I think the other thing about the tumor board is it's really rewarding to discuss cases which we have made decisions for, say, a couple of sessions ago. And that's what we try to do, because we try to make sure that whatever decisions made, we come back about 3 or 6 months later to give an update of those patients that we've discussed and to really see the results. Did we make the right decision? Was the appropriate treatment given? And I think that gives a lot of encouragement to us attending the tumor boards. And it also allows for members of the tumor board, say, who don't necessarily see the patient clinically, so our radiologists, our pathologists, for them to get a sense of what they're actually doing in the room is actually really impacting how patients are actually doing at the end. And lastly, I think to solve some of the questions of the limited numbers of molecular pathologists, so within the Asia Pacific group, the ATOC, so Asia Thoracic Oncology Research Group, we actually have a Asia Pacific wide molecular tumor board that's held once a month, where we share the resources of the wonderful molecular pathologists based in Singapore, and we just send them information, and we're able to actually conduct it sort of Asia Pacific wide. So that is a way of trying to make good use of the limited number of molecular pathologists.
Well, that's a great insight. I think there are huge networking opportunities around molecular tumor board discussions, and I'm glad to hear we are that we are contributing to the field. As molecular pathologists. Yeah, I would also like to mention that we as I said in my talk, we do a preliminary work before we meet with our clinical colleagues. So we involved technicians as well, and the whole team, and we try to make sure that what we put in the report actually makes sense, and that's the place where we also order orthogonal testing, and we believe that might save some time when we discuss patients at clinical tumor boards. But yeah, I think it's still work in progress, sometimes very challenging. And I completely agree that it's very nice to see clinical results for us as lab people, because that, everyone is happier and more engaged. And I think you work faster when you see good results. Okay, so I think we are at the end of our discussion. Thank you very much, Alicia. Thank you very much, Herbert. Those were great talks, and I think it was a nice discussion. We still had questions unanswered, but unfortunately we have to move on. So in the next minute or so, I think I will try to give you some future perspectives and a summary of today's presentations. So now we have to admit that molecular testing is a standard of care. It started in maybe sarcomas, lung cancer, breast cancer, but now is expanding to literally every tumor type. We have to make sure, and I'm not talking only for pathologists, but I think for the whole clinical team that takes care of patients and the whole molecular tumor board and clinical tumor board, we have to make sure that we preserve and prioritize tissue for molecular testing, which is sometimes not that easy. So that's why I think trying to envision a more comprehensive perspective of predictive biomarker testing could help. In the case of lung, I think we've seen very nice examples of how to organize your testing strategy. Upfront NGAs makes sense if you consider cost and turnaround time, but there are other options. Sequential testing, maybe real-time PCR could be also a good option in certain regions of the world. And whatever you do, make sure you put the patient in the center of all of your thoughts. So reflex testing and making sure that you integrate also the results from plasma and liquid biopsies is very, very important. Sometimes they are performed in different labs by different people. Sometimes one is an in-house effort, the other one is performed elsewhere. So, but you have to make sure, as Herbert has shown us, that everything at the end is considered in order to make clinical decisions. And finally, I agree with Herbert. I learned a lot, Alicia, from your talk around the importance of HRR mutations beyond BRCA, which is something that we all have in mind and it's been going on for decades. But it's not only BRCA1 and BRCA2. what's important in prostate cancer, and also MSA high and microsatellite instability. It's a tumor agnostic possibility for all of our patients. I was also very intrigued on how to organize germline and somatic testing. And I think it's good to consider frequencies and have a very well-organized strategy, because you need to probably start considering both in patients with advanced prostate cancer. So thank you very much for today's presentations, and also for the discussion. And thank you very much for your attention. Thank you.